If you don't look drop dead gorgeous with this filter.
Urinary disorder.
Because you guys talking, no, I can't get my...
All right, so I'm gonna go a little bit over the structure of the male reproductive, just so we know, okay? So, they have a penis and scrotum, okay? And a lot of the system is like, it's dual system. You know, females have like three, like different systems, different things do different things. When men, it's one hole and it does several things, okay? So it's used for urine and it's used also for sperm. So you have ducts and that expel urine, and then also kind of pouches to send out sperm. So the scrotum is located below the penis, and it's a sac, and it holds the testes and the epididymis. And then naturally, when the men hit puberty or they're hitting puberty, it's supposed to look darker and it's supposed to have rugae, which is like kind of like the wrinkling. It's not supposed to be nice and smooth.
The scrotum?
The scrotum, yeah.
Why does it get darker?
It just does. It's like part of puberty. I don't know. But why does it get darker?
The hormones.
I don't know. It's just like one of those things. I have no idea. But I'm sure there's like a reason for it. I don't know. So they can't see it in the dark when there was a tiger. Like back in the days. I have like no clue. But so the testes, their main function is to make sperm. Okay? So we can have fertilization. So the epididymis is kind of sits on the outside, and that's what stores and carries the sperm to the penis via the vas deferens. So it goes there, and then it goes out, and then we have something. The seminal plasma is what is kind of like the reservoir for the testicles for their secretions. So you have an area that makes the sperm and another one that kind of carries like the plasma to carry the sperm through. So, and there's also a prostate gland, and it's supposed to produce fluid that nourishes and transports sperm. So you guys won't be quizzed on all of this, but I have a very specific reason why I'm doing this. So the urethra, which is this kind of like long tube, and it goes in between the testes. So when you need to ejaculate, it sends out the sperm. But it's also in the bladder, and it goes down the urethra to have urine. So you can have both. You can have a guy that ejaculates and pees at the same time. Just doesn't work that way. You're doing one or the other. Okay?
Isn't that where they like clip to get a vasectomy?
Yeah, so they would clip right here to get the vasectomy.
But women can do both, right? If they want to ejaculate and also pee at the same time?
Well, it's two pathways, I think, because you have two different holes for it. Yeah.
Right, but they can do it at the same time while men.
I don't know. I'm guessing yes.
Jonathan, where's Miguel?
Yeah. I also looked up the question about the scrotum being darker, and you're right. It is because there's an increase of sex hormones that cause an increase of melanin in the scrotum.
Yeah.
Causing it to be darker.
Yeah, something like that. Good to know.
That wasn't my question.
So semen, so sperm is sperm, but semen is sperm with seminal plasma. So it occurs to get a woman pregnant. It's the main function of it. Now, puberty. Puberty for men or boys usually starts anytime between 11 and 16. So if you have a 16-year-old male who is not having like a deeper voice, who is not growing, whose testicles are smooth and they don't have hair, then you're worried about delayed puberty, and that's when you're worried about, are they getting enough growth hormone? Endocrine, now look at that. So during that time, during puberty, there's rapid change. This is usually when the boys are growing like 2 inches every night. I don't know. They get really big. You start having changes. They start being interested in girls. they start, pubic hair, voice changes, they start getting muscle mass, they start becoming men. So Tanner staging, I like to include it, but I'm not going to test you on it. So Tanner staging, when I was working primary care and I was doing physicals for boys, I would have to chart the Tanner stage whenever they would come in for physicals to make sure that they were progressing. So Tanner stage is pre-puberty. That means it's a 5-year-old boy, there's nothing going on down there. Stage 2, it's you have enlarged scrotum and testes. Sometimes you have some usually the penis starts to elongate. You might have some hair here and there. So that's when we know they're starting puberty. There's going to be rapid growth soon. And that's usually when I talk to the moms about, hey, they might start, needing more privacy, which is fine. They're going to start growing really rapidly. They might start having growing pains at night. When they lay down, they're going to say, oh, my knees hurt, my legs hurt, my arms hurt, and that's normal. Stage 3, it's enlargement of the penis. And then further growth of the testes. Stage 4, it's almost like adult, but there's not as much hair and the testes aren't as dark. And then stage 5, you're an adult. It's all there. So male hormones, I'll kind of briefly touch on this. It's not going to be on the test, and we covered it in endocrine. So the anterior pituitary releases follicle stimulating hormones and luteinizing hormones, and this is what initiates your sperm production, your testicles to kind of go into it. Testosterone is released, which is very important for men. Because testosterone is what promotes the maturation of sperm, and it makes you have secondary sex organs. So if someone has low testosterone, they won't have the deeper voice. A lot of the times they have sexual dysfunction and things like that. Okay? So normal assessment findings. So when you're doing an assessment for your patients, a lot of the times if they're in the hospital and you're on a tele unit, I'll be honest, you're not looking at that penis. You don't care what's there unless there's something big, like a wound or something. But I've never told a guy, okay, I know you're here for chest pain, but I really need to assess your penis. Never. That's never happened. Even when when they were going to the cath lab and I was a pre-op, for them to go into the cath lab and I had to shave their groin, I just put a towel over it. I never in my life had I been let me really take a look at that, unless I'm putting a Foley. Okay? But you should have palpable testes in the scrotum. They should hang loosely and have rugae, which is the wrinkling. Smegma underneath the prepubis, so when they're not circumcised, it's normal to have that. That's actually something protective. And the stream should be adequate for voiding. So when they go, it shouldn't be a dribble. It should be a normal flow.
Not even for primary care, you had to do...
For primary care, I did. But I'll be honest, unless they were older and they had a problem, the only time I would be assessing the penis really well is when someone came in reporting something going on with their penis. If they're or if they were I worked for a brief, a good 6 months, I covered at the Long Beach Health Department. So I was doing all the STDs and STI covers. I was a nurse practitioner there. And that's when I did most of my assessments of the penis. Because they were coming in for STDs. They had some sort of incision or sore or skin tag, and I had to see if it is it HPV, is it syphilis, what is it? So that's when I would do the most assessments. But generally, you guys know, if you guys go to your primary care doctor, unless you're having a pap, do they really go and check your vagina? No. I don't, I very rarely do I'm let me take a look. With kids, yes, because kids are developing. So you see me testing the testes, looking at the penis when it's babies, because I want to make sure everything's in the right place. But with adults, I'm you should know if there's something wrong. Okay, so hypospadias. So this usually gets detected at birth, but if it's not severe enough, some men will have it as adults. So what ends up happening is when the penis is getting formed in utero, the opening should be right at the tip. Some people don't have that. The opening is lower. Some people It's in the actual like scrotum or the actual like shaft of the penis. And what ends up happening is in utero, something happened. Usually, you know, it can happen with mothers that are advanced maternal age. Obesity can have that happen. Also, if they're on fertility treatment, so some women, you know, they're getting hormones to keep the baby in. Those hormones do go by with the baby. And usually when the penis starts to form, it all starts as one organ and then it elongates. There's chances of them having hypospadias. A lot of the times it's just a surgical procedure to correct it. They go in and bring out the urethra and move the opening. At times, if it's this one, they're just like, leave it. But one of the biggest signs is if you're not circumcised and your baby's peen and then all of a sudden you get a big bump in the shaft, you're like, why is it coming out that way? Or if you don't see like a hole in the tip, that's another indicator. So that's why with babies, I look at their penis really well and I make sure everything looks good. All right, and I'm gonna tell you why I went over history. When I was a brand new nurse, well, I wasn't brand new. I was like 6 months into working in the hospital, and I got report. And it was this like seasoned nurse, Marga, still remember her name. She gave me a report, and she's like, okay, you're getting this male patient. And I worked in a step-down unit, like a step-down ICU unit. So I had my 5 patients, because there's no ratios in Arizona. And I'm getting a report, and she goes, okay, this patient is actually pretty simple. He's this guy, came in, he had a heart attack, he has a lot of edema, he has an inguinal hernia, and it's huge. And I'm like, okay. So he's like, his scrotum, you know, it looks a little odd, and she gave me the whole report, and I'm like listening, I'm like, okay, take down my notes. So I go in to do my assessment, and this was a very big patient, because we had bariatric beds. So the patient is laying there kind of half up, and I come in, you know, with my computer. Hi, my name is Matilda. I'm going to be your nurse today. I'm looking at orders, and I'm like, all right, let me do my first assessment. So the patient was bigger, so he didn't want his gown on. So it was kind of draped over him. So I go in, I do my assessment, I listen to his heart, and then I'm like, oh, I'm not going to remove the gown. Let me listen to his abdomen. So I go through, and I'm like, you know, listening. So the gown is here, and I'm like listening, you know, okay, bowel sounds. I go around his belly button. The guy's looking at me like, okay. Doesn't say a single word to me. And then he goes, I'm giving him his meds. I looked at all my orders. I'm charting in the room. He goes, oh, honey, can you give me the urinal? And I'm like, well, you got it. I'm going to give you the urinal. And I'm like, he's going to need help because the penis is hiding under the gut. You know, how is he going to get to it? So the guy is sitting there, and he starts poking at his abdomen. He starts poking. And out of his abdomen, where his belly button should have been, a penis pops up.
What?
And he starts peeing. And I'm sitting there with my stethoscope right around my neck, horrified. I turn bright red, and I walk out of the room. I wasn't listening to his abdomen. I was listening to his balls.
That's why I don't put my stethoscope around my neck.
And you know what's the worst thing? I heard bowel sounds. So I came out mortified. I had already charted my assessment, so I had to go through and change everything because I thought, like, her assessment is so wrong. Let me put in the right assessment. So I had complete different assessment from the previous shift, so I had to go back and change it because I didn't realize that I was listening to his balls, not his abdomen. And let me tell you, this guy didn't say a single thing to me. He was alert and oriented. So he's probably sitting there like, why is this like dumb girl listening to my balls with her stethoscope? And I went out and I told one of my coworkers, and she told everyone. So everyone was like, Matilda, did you listen to your ball sounds? Like for 2 months. So that is why I always say it is good to know your anatomy because it might look different and you might be listening to ball sounds. But yes.
Yeah.
So what was his really
Yes, so he had inguinal hernias. So what that meant is that all his bowels got pushed into his like scrotum. So his scrotum like legit, guys, like, I'm not kidding. Like, I know, like, he was like sitting here, his chest was here, he was like sitting, and then he had his gown draped like kind of like this. So his abdomen was here, but his balls were like this big. And they were so swollen that he had an innie. You know, his penis was inside. So, you know, instead of removing the gown and being like, let me really take a look, I would have seen that there was a belly button up here and it wasn't that one. But I went through and I listened like a good nurse. And the guy just looked at me, didn't say a single thing.
Well, in your defense, you heard the bowel sounds. They were inside.
They were. There was bowel sounds because there was bowels in the scrotum, so it's normal. But just think of how embarrassing. I had to be with that guy the rest of the night. Like, I had to go in there several times and be like, hey, sir, I'm your nurse. Let me explain your disease process to you. And this guy's probably like, she's like over here touching my balls and listening to them. Like, how much confidence was I spewing? Not very much. So, yes. So mistakes happen. So know your anatomy. Remove gowns.
Can an inguinal hernia be caused by like alcohol syndrome or like anything that's like that causes a defect like that?
It could, and any sort of pressure, like weakness in the muscle that just went through. Mm-hmm. All right, get back to our lecture. All right, so commonly prescribed diagnostic tests. So usually if a male comes in, you know, there's a reason to do a lot of testing. Usually these testings get done either because they're having some sort of symptom, like, oh, I'm having weird discharge, it hurts when I pee, you know, I'm not peeing well enough, but you could do several tests. One is a testicular self-exam, just kind of like a breast exam. If you work in a clinic, guys are supposed to like check their testicles once a month to make sure everything looks good, just like women do their breasts. So that's one of the things. If you find anything abnormal, like I'm doing an assessment and I notice there's like a little ball or something feels swollen or there's something there that shouldn't be there, I'll order an ultrasound to make sure that there's no lesions, no cyst, or anything like that. You can also do hormonal tests. So if a guy comes in and says, hey, I'm 20-something and I just can't have sex. Like my penis won't go up. No matter how much I try, I want to do it, but I can't. I usually look at their meds. There's a lot of meds that cost stuff. If everything checks out, I do hormone panel. I check their testosterone to make sure that they're not deficient in it and see if something else is going on. If it's like a 75-year-old man, I'm like, here's your Viagra. Have a good day. Okay, you can also do digital rectal exams to check for prostate cancer. I have never gotten a male to agree to it. So they're not done very often. Remembered my battery was dying. So that one, you check the prostate, you go in through the anus and you feel the prostate to see if it's rubbery, if it's bumpy, if you feel anything abnormal. Then there's also a cystourethroskopy. This is to check if there's any urine obstructions. So what they do is they usually put a Foley, fill it up with fluid with some sort of dye, and then they do radiography to see if there's any kinks or anything going on anywhere. PSA, that one is prostate specific antigen. So the PSA is kind of like a hormone byproduct of the prostate. So on males, starting at the age of 45, you start to check it. But now it's kind of become a standard. If anyone is having any problems with urination or anything, you check it, because that could mean they're either having a prostate infection or that they're having prostate cancer. So usually with people that come in after the age of 45, I do a PSA with every visit in their physical. Or if someone comes in and says, hey, I get up to pee at night 2 to 3 times and I feel like I don't empty, or it takes me 5 minutes to get the stream started, or my stream is really weak, I'll check that to make sure. If it's elevated at a certain number, I'll order ultrasound and send them to urology to see what's going on. And then there's the prostate acid phosphate, and it checks for prostate cancer. Before this lecture, I had never heard of it, so
Okay.
it won't be on the test. Okay, so testicular disorders. So males can actually have disorders of their testicles. They can have an inguinal hernia that goes down to their testicles. They can have what's called hydrocele, which is when fluid fills the testicles. So they just look swollen. And this is actually a benign condition. It occurs most frequently in babies. So you'll notice when babies, like little males are born, they'll have like really swollen balls. That's what it is. Or testicles.
You said hydrocele fluid fills the testicles or the scrotum?
The scrotum, sorry. The scrotum.
Oh,
So it
okay.
goes around.
Okay.
Yeah. It's just fluid. It doesn't cause anything. It doesn't do much. Eventually, it'll just kind of go on its own. It's just a condition you watch to make sure no other complications happen. Then you can have undescended testicles. And, you know, people that grew up in places that didn't have good going to doctors and stuff, there you can have some adults with undescended testicles. So if it's like their first exam, you always ask them, when you feel your scrotum, do you feel 2 testicles? Because it should be a testicle on each side.
Oh, like they didn't come down?
Yeah, they didn't come down, so they kind of stay up in the abdomen.
And that increases the risk of having cancer.
Yep, and a lot of the time it can cause infertility. So, yeah, it kills all the sperm. So inguinal hernias, you guys know, the intestines go down.
What are those underwear for? It looks like
So this one, I think, I have no idea.
That's for hernias.
Yeah, for hernias, to keep the hernia, it's kind of like a corset, kind of for that, to keep pressure.
Should they use that if they have an inguinal?
Especially if it's trying to protrude down to the testicles. Because you just think the testicles are just skin that's supposed to stretch and shrink. So if you have intestines that go down, it can just stretch to a big size.
And also they mostly use it after they get the hernioplasty, so it stays like there.
Stays tight, yeah. So testicular self-exams, I kind of put this, usually if you're the LVN talking to the kids, you can be teaching them this. Starts during puberty, you do it once a month. Do it during a convenient time like after a bath or shower, when the scrotum is more relaxed. It should be quick. All you do is kind of cup one testicle, make sure that you feel something inside of there, that you don't feel any other bumps, that you become familiar with your testicles, okay? Just like women, you do the self-breast exam, not because it's so often that you catch something, it's because if you notice a change, you'll know what your breasts were before. Because we all know like breast and testicles aren't like smooth and perfect. They have like grooves in places, so you should know your own body. All right, so prostate disorders. So the prostate sits right in between, kind of like before the penis, in between. So if you have any problems with the prostate, one of the most common things is that you can get prostatitis. So what prostatitis means is it's an inflamed prostate. And it can be caused for any number of reasons. The most common for young men is an STD, so gonorrhea and chlamydia. So the prostatitis is inflammation of the prostate gland. It could be acute, chronic, and sometimes it could be asymptomatic. So it's usually caused by bacteria ascending to the urethra. It can be caused by a UTI or any surgical instruments. Most of the time, if you put in a catheter, you'll get some sort of like prostate inflammation because you're putting in a foreign body. But it's usually a bacteria that has descended up. And for guys, having UTIs is not as common. Prostatitis is usually seen, which is more common because they have such a long way to go. So prevention of it, make sure you completely empty your bladder, you avoid alcohol, and avoid high-risk sexual practice, just because gonorrhea and chlamydia is the most common cause. So signs and symptoms are fever, chills. Usually they have to go frequently and it hurts. And they can get some low back pain, and they can have some perineal or post-ejaculation pain. So it'll just be painful. Kind of like a UTI in a woman, they'll have those same side effects. And the higher it goes up, it goes into the bladder, into the kidneys, then they'll get the systemic side effects.
You said males 20 and up?
Usually, like, what I say is like males like 18 to like 30. 18 to 30 is what I say. Anyone of reproductive age. So just think when men are most actively having sex, and it's during that range. So every time I would get one of those like demographics, a male in that clinic, and they were actively having sex, unprotected sex with more than one partner, or even if it was with one partner, if their partner was having sex with other people, I would always test them for stuff. So the complications from prostatitis can be urinary retention, problems with erection, ascending infection, and it could cause an abscess, epididymitis, and prostatic calculi. And then so the diagnosis, you could do digital rectal exam and you would notice that the prostate was inflamed. You could do a urine culture and sensitivity because then you would see that there's an infection. Cystoscopy or an increase in PSA. In all honesty, if a male comes in, you do STI testing and you do a culture and sensitivity. If an older adult comes in, I would do a culture and sensitivity and I would probably do a PSA. Cystoscopy and digital rectal exams are very invasive. So I wouldn't, if someone comes in, they're like, I'm probably peeing, I would be like, drop them, you know. So the treatments are antibiotics, you know, Septra and Bactrim or whatever they need. Yes?
Quick question. So if you say you work at a STI clinic, what would you see first? The prostatitis or the gonorrhea or chlamydia?
So a lot of the times men have no symptoms with gonorrhea and chlamydia. So if you do see it, if they come in for like penile pain or something, it's because it infected the prostate and that's why they come in. But a lot of the times in STD clinics, men come in, women come in, and none of them have symptoms, and then they're positive for a while.
And if they don't have symptoms, but they come in, would you recommend them to go and check what they have?
Yeah.
Okay.
So when you, it depends on certain demographics. So in the health department, it was usually people that didn't have a primary care doctor. They were sexually active with a lot of people. A lot of them were like homeless kids that, you know, that either did work on the streets or did, you know, they had multiple sex partners. So they would just come in every 3 months and get tested to make sure that they were okay. And then, or you would get some people, you know, that were married and their husband cheated on them or their wife cheated on them, and then they would come in to get tested. So some of the times, you wouldn't see any of this. But if you would see it in someone young, you would know it's likely an STD. But usually men have no symptoms with bacteria unless it's getting pretty bad. And that's when you see the prostatitis. There. So for them, NSAIDs and stool softeners, and the reason you do stool softeners is because the prostate and the GI tract are pretty close to each other. So if they are constipated and a bowel movement is going by, it's gonna really hurt. So that's why you give them stool softeners. You can give them a prostate massage. You can do dietary changes like less spicy food and all of that just because it's by the GI tract. You can also give them like an alpha beta adrenergic to relax the bladder and decrease the pain. And then prostate surgery if it's really bad or it becomes a chronic issue where you're treating the bacteria but it's still inflamed. So this is the most common disease that you'll probably see, and I'm sure you've seen it in several of your patients' diagnoses or histories. It's called BPH, benign prostate hypertrophy. So what it is that it's an enlargement of the prostate gland. So normally it sits right here. This is a normal prostate, and you see the bladder is up there and then the urethra is coming down. So when the prostate is enlarged, it has nowhere really to go on the outside, so it grows kind of in. So instead of having a nice open flow of urine, it becomes very narrow. And that narrowing is usually what brings men in because they're having urinary flow obstructions. It's likely to occur after the age of 50. So after the age of 50, some sort of growing of the prostate is normal, but just because you're getting older doesn't mean you're gonna get BPH. So just because a lot of people get it doesn't mean everyone will. Okay, and it's the most common male pathological condition, and the second most common cause of surgery in men over 60. So usually, like I said, they come in and they say, hey, I'm not sleeping well. And when you ask them, why aren't you sleeping well? Well, I'm getting up 3 or 4 times to use the restroom. And then I usually go in and I tell them, well, are you having a hard time starting? Are you peeing very little? Is your flow not good? And they usually say, decreased volume, force, it's interrupted dribbling. Sometimes they can have urinary retention, or they're getting a lot of UTIs, because if they're not emptying their bladder completely and the urine is just pooling there, it's easier for an infection to sit there versus if you're flushing out your urine constantly. Sometimes, in bad cases, fatigue, but fatigue is usually because they're not sleeping. And then they can have some anorexia, nausea, vomiting, and epigastric discomfort, but that's really not common. Usually they're just saying, I'm just getting up, I'm peeing too frequently. And this is like 3, 4, sometimes up to 10 times a night, they're just getting up and going. During the day, it's not as obvious because we're awake and we're just going, but at night is when it becomes most obvious. So the complications from it is hydronephrosis. So if you're not peeing out completely, your kidneys are still gonna filter and your bladder's still gonna fill up with urine. So if you're not letting enough urine out to empty your bladder, it's just gonna keep building up and it's gonna back up into your kidneys. And then your kidneys are gonna swell. They're gonna kind of become enlarged and because of it. And it can cause some renal insufficiency or urosepsis. Again, anything that pools anywhere is a breeding ground for bacteria. It can cause bladder dysfunctions, UTIs, renal stones, and if it gets really bad where it's so obstructed that they can't pee, it becomes a medical emergency because their bladder could burst and all sorts of stuff. So you diagnose it usually by a UA or a urodynamic flow study, which again is when they put in the Foley and seeing how the urine comes out, how much is left behind, and all of that. You can do a transrectal ultrasound, cystoscopy, PSA, check the creatinine. In the hospital, the most common way that they check for that, it's the post-void urine, what is it called? The name left me. When you do the bladder scan. So you let them void and then you bladder scan. And then you know if there's residual, post-void residual. Okay? And if it's usually greater than 350, you put in a Foley or an in and out cath. So, medical management. ER for severe urinary retention. If you're working in a clinic and a patient comes in and says, I haven't peed in 2 days, send them to the ER. You don't need to do anything there. Just send them to the ER. But if they're just having it every night, there's medications you can give them. Usually it's Flomax, Proscar, or Rapaflow. Okay? And if you're giving Proscar, pregnant nurses should not handle it. And it usually tells you on the label, like use gloves or reproductive harm, things like that. So this medication, what it's supposed to do is that it actually decreases the size of your prostate. It decreases the inflammation in the prostate. So if your patient is put on Flomax, when should they be taking it? At night. Why at night? Yeah, so if it's decreasing the size and that's when they have the most space to pee, you give it at night. So if they get up once, they pee all of it out. And then they can go back to sleep and sleep all night versus in the day where they pee it out and then the night it wears down and then they get up to pee more. So you do it at night so they can really empty their bladder and they get woken up less. If it gets really bad, they can have something called transurethral microwave thermal therapy, where they go in and like they heat the prostate to kind of decrease the pressure. But usually the management for severe BPH is called a TURP, transurethral resection of the prostate, where they go in and take out part of the prostate or enlarge the pathway. And you guys will see these on the med surg floors because they come in after the prostate surgery, and there's a whole slew of care that goes into these patients. After that, they get rid of part of it, so they have a large bore Foley. I'm not kidding. It looks like this, like huge. And the main reason that they have that is because you're gonna have a bag of fluid, usually 2 liters, flowing in at all times into the bladder and then out the Foley. Because they just had surgery, there's gonna be swelling. You don't want retention to happen, and you want the urine to continue coming out. But because they had surgery, there are higher chances of clotting. So you wanna flush out all that blood before they become big clots, and then they clot again, and then they have to go in with surgery again. So.
And is there also a risk of like the tissue that is left like sticking together?
There could be some risk of that. Usually when I had post-TURP patients, I'll be honest, that urine looked like there was all sorts of stuff swimming in it. So there could have been some tissue in it, but you see clots, a lot of clots, it looks like kind of like a blood tinge that's coming out. And then you have to do all sorts of calculations because their output isn't their output, because you have to subtract what went in with like saline and then whatever. So if 2,000 mLs went in and the urine bag was 2,800, then you know they made 800 of urine, not 2,800. But post-TURP, they're on continuous bladder irrigation. So that's what we're talking about, where they have a large bore Foley, and then they're attached to a bag that goes in, and then it drains out. So then it has 3 prongs. 1 prong to inflate it, 1 prong to drain, and 1 for the fluid to go in. And at times it can get clogged. So you have to like do boluses of fluid to kind of break up those clots and have them come out. So the complications from a TURP, it can be that they can get blood clots, bladder spasms, infection, but one of the most common is urinary incontinence. After that happens, the body isn't able to stop urine, so they become incontinent, and a lot of the times, erectile dysfunction. Okay? They can also be retrograde ejaculation, where it kind of goes the wrong way. So radical prostatectomy is when they remove large parts of the prostate. It's very rare, and sometimes it can be open, so that leads to a longer stay because they have a huge surgical incision, or it can be robotic, which is less invasive. Yeah?
Sorry, can you explain TURP again?
TURP, yeah. So the TURP is when they go in. Here's a very graphic picture, and they kind of get rid of little parts of the prostate, usually in the center. They go in through the penis and kind of take out chunks of the tissue to enlarge the pathway of urine. Yeah. So it's transurethral resection. So it goes through the urethra, and they take chunks of it to kind of open up the way. Mm-hmm. Whereas prostatectomies, they go in and just remove either parts of the prostate or the whole prostate. So the biggest thing is, after a TURP, what are you worried about if you're the nurse?
Urinary output.
Yeah, urinary output, infections, and clots. If you see a patient that had a TURP and you're irrigating them and they have bright red blood, is that normal? No, that means they're bleeding somewhere in there. You need to call the surgeon right away. All right, so prostate cancer. So one of the reasons we watch for whenever they have BPH is because whenever there's an enlargement of the prostate, or the cells are abnormal, it can lead to prostate cancer. It rarely does, because BPH is so common, but it's something you always watch out for, because it's the most common cancer in American men. But it has really good prognosis, because usually prostate cancer kind of stays in the prostate. It rarely travels out, because there's not a lot of pathways for it to travel. So it tends to stay where it is, and the stage is based on how it grows and spreads, but it's a lot of the time a slow growing cancer. So if you're a male and you have some sort of cancer, prostate's the one you choose. So the etiology is usually age, high fat diet, family history. There's a high incidence in African American men, and the lowest incidence is in American Indian and Native Alaskans. Also, occupational exposure. People that work where there's a lot of radiation or things that can cause things to go wrong, this tends to happen. So, signs and symptoms are rare in the early stage. Usually they come in, same as BPH. Hey, I'm having a hard time peeing. Hey, my flow isn't good. So then they look. If it metastasized because they've just ignored all the signals, it usually goes to the back because it went up their bladder and all of that. So they'll have the back pain because it's going up their urinary system. They can have anemia, weakness, weight loss, and tiredness. So complications of bladder cancer are erectile dysfunction, bladder problems, and metastasis to different places. Okay, so diagnosis, usually a PSA is done for men, and I know it says may age 50 or above, but it's now 45. And it can now be done at any age as long as they're having urinary symptoms, or 45 for high risk. But yeah, so if the PSA is greater than 7, they need to go to a urologist. They just need to. And the PSA will go up as people age. So a 20-year-old should have a really low PSA. An 80-year-old can have a PSA of 4, and we're like, you're fine. So that's why we always check it. If we find a high PSA and they're having symptoms and we're suspecting cancer, we do a transrectal ultrasound, and if something comes up abnormal, then we do the biopsy. But this is usually done at urology. So unless you're working in a urology clinic, you wouldn't see this even in the hospital, because usually the urologist follows them, they go outpatient, and then they come into the hospital to have the TURP. So therapeutic measures. So because prostate cancer, you know how breast cancer a lot of the times gets fed by estrogen, or ovarian cancer, theirs gets fed by testosterone. So if they have prostate cancer, you want to suppress testosterone. You want to suppress it to stop the growth of it. They can have a TURP if it's kind of like in a limited space. You can remove all the prostate. They can have radiation. There's even a new vaccine that's supposed to help with it. Or if there's Mets and it goes to like the testes, they can remove all of that. Sometimes if it's really bad, they might just remove the testes so it can just suppress testosterone. And brachytherapy, which is like an external beam, gets sent in, and then like the radiation is like localized. So instead of having radiation that goes out, they can have radiation this way. So it goes through the rectum and then gets pushed through to the prostate. Okay. So penile disorders. Priapism. So this is painful, persistent erections lasting several hours, sometimes days. So usually any erection men have greater than 4 hours, they should be sent to the ED. Okay? Just because there's such high risk for injury.
Why does that happen? They take too much something?
So it can be for any reason. Sometimes it just occurs. Sometimes it can be from like sickle cell disorders, cocaine use, or they put some medications, spinal cord injuries, anesthesia, penile injection therapy. Like sometimes you're able to, you know, if the men aren't developing the way they should, you can give injections to make them have like erections. So sometimes that can be the opposite of it. Most of the time when men come in with priapism, it's because they took some sort of drug, usually cocaine, or they're young guys that somehow took Cialis or Viagra because they wanted to do it all night, and now it won't go down. So So that's one of the things. And the reason this is a big emergency is because what ends up happening with priapism is that the penis is filled up with blood and it's hard. And we're worried about it because if it's filled up with blood and it can cause some necrosis or it can damage the penis. So it won't work the same because it's like engorged with blood. So we want to get it out. Sometimes they can do it with medication. A lot of the times they put a needle in and drain the blood out. Okay. Now phimosis, that's when the foreskin is so tight it can be pulled back. So if they're not circumcised, and usually with boys, you don't try pulling the skin back anymore. They found out that there's more trauma. But as a grown man, you should be able to pull your foreskin back to see the head of the penis. And if they're not able to do that because it's so tight, then it's called phimosis, which means it's kind of there. And the reason we worry about it is cleanliness. It's also very painful. And sometimes if it gets so tight, it could cut off circulation. A lot of the times, it comes with STIs, usually syphilis. So paraphimosis is when the skin is retracted and then it doesn't return to the same position. So this one, we care about it, but this one is a medical emergency. Because if they somehow pulled back and now it can't come and it's tight, it's gonna cut off the circulation. So that one, if they say, I pulled my foreskin back and now it won't come back down, ER, they need to have surgery. Okay, so balanitis is an infection of the skin covering the head of the penis. Usually happens to uncircumcised or people that have poor hygiene, but I usually don't see it as poor hygiene. The people that come in with this most commonly is diabetes patients because there's such high risk for fungal infections. So that's when inflammation here. So now, a vasectomy. A vasectomy is done when men don't want to have kids, so they go in for the procedure. So it's elective sterilization, and it can be done at office clinics, usually urology offices, and it's very weird because if women, when they go in and if they want to get their tubes tied or something, they sign a consent and they're good. If men under the age of like 30 want to have this done, they have to talk to a psych doctor to make sure that they're like in their right mind. It's like a whole thing. Like they'll be like, are you sure? Are you positive? Like they're very like crazy about it. So when it's done, what they do is that they kind of go in the testicles, and they go in and pull out the vas efferents, so the kind of like the pathway for the sperm, and then they cut it and then they stitch it up. It's usually done within 20 minutes. And the biggest thing is if you work in a urology clinic, is men think, oh, I'm gonna come in and get the snip. It's 2 snips because you have 2 testes. I've had people be like, and then they went to the other side. They're like, it was 2 cuts. And I'm like, yeah, you have 2 testes. And they're like, no one told me that. No one. We're like, I didn't think I needed to tell you that, but okay. So, and the biggest thing is the testes are making the sperm, but the sperm has been there because usually it makes it and there's a storage unit. So the number one priority after a male gets a vasectomy is to tell him, hey, it's gonna take about 3 months or 30 ejaculations for you to be sperm free. So if they go, because they're not supposed to have sex for a week after, if then they're like, oh, I'm good, and they go out and have sex, they can still get people pregnant. So if they want to have kids later on in life, they can do some sperm banking, but post-op, most of the time, they have some bruising and some soreness. You could put ice packs on it and then give them some Tylenol, not ibuprofen because it causes bleeding. And then they wear like a jock strap to kind of support their testes.
It's reversible, right?
They say it's reversible if it's done sooner, but a lot of the times once you go in and cut, you get fibrous tissue, so it's not always reversible. Yeah. But if it's done and it's done like within a certain amount of time, it's pretty successful to have it reversed. So usually you tell them to avoid strenuous exercise for 5 days, take it easy or off of work for 2 to 3 days. Some men return back to work right away, others take 2 weeks off. It all depends on the male and how they feel. Sexual activity cannot happen for 1 week after. And use reliable contraceptive. So usually when you go home, they give you a cup. And in 3 months' time, they tell you you're supposed to ejaculate into this cup and take it to like Quest Lab. And then they'll run it to make sure that there is no more sperm in the semen. Okay, and once they say that you're good or it's very low or almost no count, then they'll tell you you're good to go. But until that point, they're still considered fertile. Okay? So you tell them after they go home if you're having severe pains, swelling, or fevers, let us know. Because then that means that they could have an infection or something else is going on. So erectile dysfunction. So erectile dysfunction is the inability to get an erection or to keep it up. So it's either one. So it can be from a disease affecting blood flow, nerve disorders, stress, injury to the penis, chronic illness, or unhealthy habits. So a lot of the times I work cardiac. So this is something we deal with a lot because I give out medications like beta blockers, blood hypertension medications. So just think of what an erection is. All the blood flow goes there and it increases the pressure of the penis, and that's what makes it stand up and engorge. So if you're giving someone beta blockers or blood pressure medications, your body is being told by that not to do that. So a lot of the time, especially with beta blockers, there's erectile dysfunction. Okay? It can also be for different stuff like psychological reasons. So usually the way you diagnose it is you look at the medications, sexual history, you do a full physical exam, you test their glucose because diabetes is one of the biggest causes. The blood has so much sugar, and sugar is an irritant, and it irritates all the vessels, including the penis. So just think, if you get numb on your feet because it's messing up with the nerves, same thing can happen to your penis. Okay, so I always tell people, especially like men that are having trouble, we got to get your diabetes under control or else this is going to continue to happen. Okay, we look at their liver, their heart, all their blood work. And then if you don't find any probable cause, you're like, this guy is healthy, nothing is going on, you can look at vascular flow studies, or you can do some sleep studies to see that during the night their blood pressure isn't dropping or anything like that, or that they're having like sleep apnea and that's what's causing everything to go on with their heart. So, yeah.
What about like excessive alcohol use or like
Yes.
drug use and stuff?
Yeah, so excessive alcohol use. So alcohol is a depressant. It depresses everything. It usually makes your blood pressure go down. So that's why, the word whiskey dick comes out, because your blood pressure is so low, you're so relaxed. It's a depressant that they can't get it up. But usually once they sober up, it goes back to normal. Okay? So the biggest thing with this is that they have to have counseling. You have to tell them this can be very traumatic to men, especially when they have the urge that they want to do it and that they can't do it. And a lot of the times, these are older men that are married and have been married for years, so it can be very traumatic for them not to be able to. We can also change their medication. A lot of the time, if they're on metoprolol and they got put on for some reason, they were having high heart rate, but it's controlled now, I'll try changing it or lowering the dose to see if that helps. Hormone, I tested testosterone because a lot of the time if they have low testosterone, that's the reason. We can give them the androgen gel so it can stimulate more testosterone. We can give them herbal remedies. We can do a transurethral suppositories if you know it's constipation or something else is going on, and then we can have injected med to cause the penis to vasodilate. So this is when I said, oh, the injectable medication that can cause priapism. Some men go in and get an injection that causes vasodilation, so it becomes erect. But it can cause priapism. So I don't know. I don't know any men that would be okay with that, but with the needle. So there's also mechanical aids that can be used for it. So teaching them about it, you know. There's the suction devices that causes the blood to go in. Now there's penile implants that can be put in. Usually this is very severe. That doesn't even, sometimes Viagra doesn't even cut it. So that's when they would do the penile implant, especially if they're young men. So what they do is that they go in and they blow up the implant and then they become erect. And then vascular surgery, if they have any vascular issues. So erectile dysfunction meds. The first line is Viagra, Cialis, and Levitra. One of the biggest things is avoid nitrates. If you take a nitrate within 24 hours and then you take a Viagra, it's gonna cause severe hypotension. Like hypotension so severe it's fatal. So you tell them anytime I usually don't give these medications if they take nitro. If I see them take nitro or isosorbide, then I say we need to discontinue this med if you want Viagra. Like we cannot mix both of them. So what it does is that it vasodilates, so it allows more flow to go in. We usually tell men to take it 30 to 60 minutes before commencing sexual activity. So
taking nitrate and, for example, Viagra will cause pre-hypotension.
no, so hypotension. Because nitrates, what do? Vasodilate. And what does Viagra do? Vasodilates. So if you take both of them at the same time, they have a synergistic effect. So they'll make you vasodilate so much that it's life-threatening hypotension.
But they won't cause pre-hypotension.
Huh?
They won't cause the pre-hypotension.
No, the priapism can cause if like someone young takes it and they take Viagra and then it doesn't go. But if you take Viagra with the nitro, vasodilation. If you take Viagra on its own and for no reason, it can cause priapism, which means long erection. So one of the things, elderly and cultural diverse populations, I always tell people, men have the capacity for sexual activity throughout their lives. The oldest man I've ever given Viagra to was 96. Yeah. I was like, okay, sir. You want it, you got it. Okay? But, huh? What?
Funny, but is it actually effective for them at that age?
Mm-hmm.
Wow.
Yeah. Yeah. I mean, I didn't ask him, but I'm guessing if he's asking for it, because he's had it in the past and he didn't come back being like it didn't work, so I'm guessing it worked. But theoretically, it should, because they still have like vascular there and it's doing what it's supposed to. But if you're a lot older, the response can be a little bit slower or reduced. So you tell them, hey, you don't take it 30 minutes before, take it an hour before. And then, erectile dysfunction is more common in the elderly. It's not something that should be expected in the elderly, but it's more common. And then you can also stop meds if they're having a side effect, like a sexual side effect. So a lot of elderly may not be screened for STDs. When someone comes in and they say, hey, I'm not able to have erections, and they're 80, most people don't think, oh, it's an STD. But you have to realize some 80, 90-year-olds are still having sex, especially nursing home. You get a group of people together, and they do. And at the VA, there's been times that you have to give them privacy. You know, when they're in the nursing homes, because it's their right to do what they want. And so you still screen them for STDs, and we often forget that. So elderly people are like one of the biggest undiagnosed population with syphilis. So cultural biases may exist. You know, people think, you know, you're old, don't do it. They don't do it. They don't need to do it. But a lot of the times, you know, being able to be sexually active goes with masculinity. It's how they define themselves. And, you know, you have to think of those considerations. So nursing diagnosis for erectile dysfunction, readiness for enhanced acknowledgement of treatment information for erectile dysfunction, self-esteem disturbances, and sexual dysfunction. So someone, and I don't expect these to be in your care plan, like, in all honesty. If you put this on there, I'm gonna be like, how did you ask? Like, how was that brought up? All right, for the prostate, like prostatitis, it can, or BPH, it can be insomnia related to nocturia, urinary retention, risk for incontinence, for TERPs, you know, acute pain because they just had surgery, deficient knowledge of post-op care, risk for fluid volume deficiency, infection, urinary retention. Any questions? Oh, one of the biggest things I think I didn't mention is some of the medications that can cause not only blood pressure and hypertension, but also depression medication. Zoloft, it's one of the biggest ones. So if you see someone young that's not being, has a history of depression, it might be Zoloft. So you would change that to something like Wellbutrin, because that one doesn't have those side effects. So medications play a huge role. Okay? All right. Any questions? All right, we're good to go. Yay!
Professor,
Yeah?
how do you spell the medication?
Oh, for which one? Zoloft?
Yeah.
It's Zoloft. Zoloft.